ability to form transformative partnerships has led to his many great successes. Under his leadership, the Stanford Pain Management Center has been twice designated a Center of Excellence by the American Pain Society for the center's innovative approach in comprehensive, interdisciplinary, and outcomes-based research. He has served as principal investigator on multiple NIH awards, where he has overseen efforts to map the specific regions of the brain and spinal cord that perceive and process brain. He is also the author of over 200 journal articles and book chapters, in addition to numerous national and international lectures. Currently, he is developer of an open source learning health system, Choir, to transform the care of people with pain and serve as a platform for research in real-world clinics. Dr. Mackey is past president of the American Academy of Pain Medicine, and he has co-authored the Institutes of Medicine's report on relieving pain in America. He has received multiple awards for leadership, teaching, research, and clinical care. And we would like to thank him for his support and collaboration in helping us move forwards with our work in implementing a learning health system to improve pain for patients in our province. So please go ahead, Dr. Mackey.
Great. Thank you, Regina. And it's wonderful to join you virtually. Hopefully sometime I can do this in person. And delighted to share with you some of our experiences in the development of a learning healthcare system, and hoping that we can build on this together and really help transform the care of people who are suffering with pain. As was mentioned, I work at Stanford. I am a physician scientist. I still care for patients about a day a week. I spend the majority of my time in the lab, and our research informs our clinical care, and our clinical care clearly informs our research. And I think you'll see that represented here in the talk that I'll provide today. So let's dive in, shall we? And you know, the topic here is about learning healthcare systems and using them to optimize care, as well as for real-world research and discovery. And I invite you to take a step with me, and if you will, imagine a world. By the way, let me just do an audio and a video check. Regina, is everything coming across okay? Do you see the slides and hear me okay? Great. Yes. By the way, I got to give a quick shout out to Regina. She's amazing. There are those people in the world who get things done, and she is in that rarefied category of people who gets things done, and gets things done in a very impactful way. So I really have enjoyed the collaborative relationship with Regina, as well as just admired her intellect and her, like I said, getting things done. So let's take this step forward. And if you will, let's imagine a world. Let's imagine a world where clinicians access high-quality data that informs their assessments and best treatments through clinical decision support systems, that data is continually updated, that new data types are added dynamically all the time, and the systems are continually learning from that, that targeted delivery of therapies, both online but also in person, are based on a patient's unique characteristics and their data. If you will, imagine a world where researchers working with real-world data to generate findings that generalize to a broad clinical population, and not just the typical homogeneous populations that we usually see in randomized controlled trials. That systems are connected and the data is analyzed across multiple institutions, but that data never leaves the local site. It always stays at the home institution. And finally, imagine a world where patients can access their own health information and use it to improve their education and self-management of pain, as well as other conditions, that these patients work collaboratively with their clinicians to further empower their individual care. And it's this world that I have been, if you will, imagining, and many others have been now for quite some time. And I'd like to take you on that journey and see how we've been working to make that world a reality. So it helps to start with a use case, if you will, a patient example. And so Sandra here Sandra has given me permission to talk about her, and I use her as a typical use case. Sandra has neuropathic pain. When she was 20, living in upstate New York, she was driving to college, listening to Britney Spears on the radio. She was T-boned out of the blue by another car. She ended up with an ankle injury, taken to the emergency department, where she was released shortly after because they could find no injury other than soft tissue, but her ankle has been on fire 24 hours a day, 7 days a week for the last 15 or more years. She has complex regional pain syndrome. Sandra moved to Florida, where she works for Walt Disney World, and flies out to see me at Stanford on an intermittent basis for care. And I will pose to you a question about Sandra that applies to every other patient that we see, and that is, how do we really know whether we have made Sandra better? And how do we know what better really represents? And also, how do we know whether a certain treatment is better than another treatment for Sandra or for any other patient for that perspective? And I'll share with you that the answer to that is not what we usually go on, which is belief. It is the pattern classification. It is what we've learned from our mentors. And I love this quote from George Bernard Shaw on belief: "There is no harder scientific fact in the world than the fact that belief can be produced in practically unlimited quantity and intensity without observation or reasoning, and even in defiance of both, by the simple desire to believe, founded on a strong interest in believing." And at the end of the day, unless we have real data, all we are docs with opinions. And so we need more than belief. Now, this is an expert audience, and so I'm going to just skip through these slides quickly. These are the typical dilemma slides where I'm going to impress upon you the problem of pain. This audience gets that. You know, in our country, 50 to 100 million Americans. More recently, we defined this concept of high impact chronic pain, where there's 20 million with high impact chronic pain, that pain that has severe impact on their activities of daily living. We did this through efforts through our national pain strategy that I co-chaired. One of the key messages in both the IOM pain report and the national pain strategy is that we need better quality data. And that was represented here in the NPS that we put forward, that we need better data to understand the problem and guide action. The quality of the data that we have is just terrible. Now, my journey on this started 20 years ago, almost 20 years ago exactly, when I came on as a young faculty member and our chair, Ron Pearl, took over the department at that time. And Ron met with me and he said, you know, Ron, he said, no, you know, Sean, I only have four problems with your division. And I, being an engineer and loving to solve problems, I said, Ron, give it to me. What are the 4 problems? We'll get them fixed. He said, it's your clinical care, it's your finances, it's your education, and it's your research. And that was rather sobering. And the truth is, we were a much different division 20 years ago than we are now. Our finances were terrible. We were losing $500,000 a year. We couldn't attract any fellows. We had 0 research funding. But I said, Ron, you know, our clinical care is really superb. We practice in a small multidisciplinary clinic. And he looked at me and he said, how do you really know you're helping these patients? And I realized that I couldn't answer that question beyond saying that they give me fruitcake during the holiday and bottles of wines and hugs. And I told my son, who was born at Stanford and was 2 back in the 2000, and he said, Dad, that's unacceptable. And so it put me on a pathway of committing myself to figuring out, are we actually helping these patients get better? At the same time, I was building up a career in neurosciences. So I joined up with Dan Carr at New England Medical Center, who developed an instrument called the TOPS. It was a paper and pencil instrument. It took 45 minutes to fill out. And I gave that to our patients for 8 years. And I learned tremendously from that experience because it was an unmitigated failure. What I learned is that patients hate filling out those long, tedious instruments, particularly when they don't get anything back from it. At the end of that 8 years, the patients hated me, the staff hated me, the faculty hated me, and I stopped doing it, and I paused and I said, I'm going to come up with a better solution. That took me to the concept of a learning healthcare system, which the National Academy of Medicine was starting to put forward around 2007, 2008. And the idea of a learning healthcare system is that it represents an informatics platform where the research is happening closer to clinical practice than in the usual university settings where you have teams of people, scientists, clinicians, administrators, and yes, also patients working together, where these studies occur in everyday clinical practice settings where we can aggregate health data in real time and it's continually updated and the system learns from that new data. That we structure this knowledge so it's actually deployed back immediately into the clinical practice. In summary, the evidence, the research evidence informs the practice, and the practice informs the evidence. And so I waited for several years for somebody to build something and realized that the only people that were doing it were trying to make a buck off it. And there was a lot of distrust from my physician clinician colleagues. And so I decided to go throw some of my endowment money at this. And I partnered up at Stanford and built a open source, open standard, flexible and free, my favorite four-letter F word, free learning healthcare system that we use for point of care decision making, for longitudinal tracking, where we engage patient reported outcomes, clinician reported outcomes. We put all sorts of data into it. We use it for comparative effectiveness research and other pragmatic observational trials. And we build on that in a collaborative way. And this is another way of representing a learning healthcare system in a graphical format where Choir I'm using as the prototypical use case. And I typically start over on the right-hand side of this figure where what we have is, let me just change the quick color of this, where we have are both clinicians entering input, we have patients entering input, they come into the learning healthcare engine, which does the patient reporting, the clinician reporting. You run research studies within your clinic that generate additional knowledge, but also you feed in the research from your typical research enterprises. And we do this in our own lab. That is then fed into your typical AI machines, your machine learning approaches, whether it be interpretable or non-interpretable machine learning. And then that is continually updating your learning engine. And this goes in a round-the-round manner iteratively. So we initially tested this at the Stanford Pain Management Center, and we're one of the larger tertiary referral centers in the country. We see between 22 and 25,000 patient visits per year. We're by definition a comprehensive interdisciplinary program. I have right now 27 to 30 pain faculty boarded in pain medicine, coming from a variety of different specialties, anesthesiology. You can read it off the screen here. We now have, this is now up to 8 pain psychology faculty, and then we integrate in a number of additional services, and then strong connections between our clinical and research enterprises. I should share that we've gone way beyond the Stanford Pain Management Center in this, and I'll give you some examples in a moment. Now, the key to making this work is seamless integration into your clinical workflow, and I'm going to be repeating that over and over again. Through that, we automate the survey reminders so they go out at specified times. We use easy-to-use data entry. There's point-of-care reporting on the patients. We have to date captured well over 50,000 patients. It's somewhere between 50 to 100,000 patients, 100,000 or more longitudinal data assessments, between 25 and 30 publications for this. And we've been giving this away for free. So the model that I've been approaching this is rather than build a company around this and trying to make a buck, and by the way, I'm very positive and supportive of the commercial sector, but I felt very strongly that we needed to make this as an open source model to engender trust and support, and then also build collaborations across academic centers and other centers. So the only licensing restrictions has been non-commercial restrictions. With all of this, we have changed fundamentally the culture of how we care for patients. Now, I'm going to share with you some of the features, other features of this. I'm not going to be getting into this one over here, StepX, which I can talk about if people want. This is a patient satisfaction module that we've added on to Choir to capture patient satisfaction because that's such a big issue here in the United States. I don't know if it is in Canada. We leverage Promise item banks, but also we use legacy instruments. We're not just tied to Promise, but we do appreciate the power of it in giving a referenced T statistic with a mean of 50, standard deviation of 10, meaning And it's normed across large populations, meaning if you've got somebody out here in Palo Alto with a fatigue of 65, 1.5 standard deviations above the mean, it's going to mean the same as someone out. I think you guys are out here. I'm geographically challenged, 65 out there at McGill. We built in a computer adaptive testing engine that significantly reduces burden to the patient by upwards of about 75% to, again, reduce that impact on the patient who's filling out these surveys. We have expanded well beyond pain. And so in addition to adult pain, we are in pediatric pain, we're in the chronic fatigue syndrome space, orthopedic surgery, trauma surgery, family medicine. We've been doing pre-surgical assessment clinics in interventional radiology. We went live in psychiatry recently and in GI medicine. These are some of the papers. I should mention, it's important to keep in mind this is an informatics platform, and it's not a survey. It's not an electronic data capture system that's fixed. And what that means is that the surveys that we capture in chronic pain are entirely different than what trauma surgery gets or psychiatry gets or the chronic fatigue syndrome. And similarly, we've placed this in multiple centers throughout the planet. It's running at the Medical College of Wisconsin. It's at it is running now at McGill, thanks to Regina and Sarah. It's at the University of Pittsburgh. And I'll share with you, for instance, what Pittsburgh is using is quite a bit different than the surveys that we use. We do a very long survey of about 40 minutes. Pittsburgh does about 16 minutes. Each of those determined by their patient characteristics. We've also translated this into multiple language on the left. You see this is the one running in Israel at Rambam, translated into Hebrew. On the right, provided, thank you, Regina, has been translated into French, and we're also translating into other languages as well. Now, why has this not happened with some frequency, these types of platforms? And the answer to that is a very simple, and that is a lack of buy-in. These systems repeatedly fail. I've seen it over and over and over again. And it's because people don't get buy-in from the stakeholders and the local constituents. The constituents meaning the patients, the front office, the back office, the schedulers. The key is you have to give back. You have to provide value to each and every one of them if you're going to get buy-in to these systems and make them ultimately successful. Ultimately, or otherwise, what happens is there's a lot of enthusiasm at first. People put them in, but then they just die a death of 1,000 cuts. So the key is seamless integration and giving added value back to all of the stakeholders involved. How do we give that added value back? One is by providing a number of reports and tools that aid assessment and clinical decision-making. We provide point of care reports to the clinicians. We also have online tools that provide automatic note generation features. And so, for instance, I can't speak for you, but with us, the EMR is the bane of our existence, and having to do clinical notes is always very laborious. And so we have with Inquire Provider a system that does about 80% of the note generation, pulling in data from Quire and generating a customized note. We also have a number of online tools such as opioid risk mitigation tools and tapering tools. I'm going to get back to how we've used those tools also in our research efforts a little bit later on. We have a number of clinical diagnostic calculators built in, and I may get to some of those a little bit later. Now, how do we use this in a day-to-day clinical situation with a patient? And here I'm going to talk about, once again, Sandra. Sandra came in initially from Florida, where she wasn't happy with the care she was getting out there. She came in, and higher scores within these reports represent worse functioning. And so she had high levels of depression, anxiety, fatigue, poor physical function, a lot of pain interference. And what I put her on after doing an assessment, she hadn't been tried on a tricyclic antidepressant, surprisingly, for her CRPS. That was easy. I've also done a number of studies on a drug called low-dose naltrexone, which is thought to be a glial cell inhibitor that has worked in fibromyalgia, and I'm running a clinical trial in CRPS. And I also do with in-clinic transcranial magnetic stimulation or brain zapping. And what we find here is that by and large, we're seeing her scores get better and better across the board with many of these domains. She's improving in her physical functioning. She's improving in her pain interference, her anxiety, her fatigue. She's improving in everything except for physical function isn't budging. And I was intrigued by this. And so what I did is I brought in one of our patient educators who worked on that and did goal setting with her, targeted goal setting. She wanted to walk more, hike more. So we set those goals, we monitored, and we found that over time, lower scores again are improvements. Her functioning went up and up and up. And I'm going to come back to this observation, by the way, in just a little bit when I talk about some of our research studies, this notion that physical function didn't budge despite everything else moving. I'm going to switch gears now out of the clinical and talk about the clinical research and give you some examples of how we've used Choir to advance our scientific knowledge. And so within this circle here, we're going to be talking about some of the research studies that we're using with this data to better inform our knowledge about pain, but then also to optimize our subsequent care. And before doing that, it's worth pointing out some of the challenges that we all face with contemporary clinical research. And I'm going to list a few of these challenges that we face. Challenge number one is the vast majority of the clinical research that is done isn't relevant to our clinical practice. And I'm going to speak for our own group as well on this. We traditionally do standard randomized controlled trials to assess the efficacy of a treatment. And in doing so, we tend to take patients that are highly homogeneous, and these studies end up with high degrees or high amounts of internal validity. However, they frequently don't translate to the real world. They have low external validity or generalizability. They frequently, we note this voltage drop, if you will, in the effect size of our treatment when we go from those RCTs into the real world. And in large part, it's because the patients that we study in these randomized controlled trials don't represent real world patients. So if you take, for instance, 100 patients, and this is a typical number that might come out of our group here, of those 100 people, we only enroll about 10 of them. These are the yellow people here. We don't enroll the other 90 people that represent the real world. Those 10% of people are typically incredibly homogeneous on no medications, no medical comorbidities. The problem is those 10 people don't represent the real world. And it's not just in pain, but it's in almost every other field as well. I provide on the right-hand side some summaries of articles that have been done showing that in the psychiatry literature, the vast majority of patients in psychiatric RCTs are excluded, thereby limiting generalizability. Challenge number two is that RCTs, clinical research, is incredibly, incredibly slow. And an often quoted statistic is, after an average of 17 years of research, only 14% of that research has led to widespread changes in care. It operates at a subglacial pace, and we need to be able to do research faster. Challenge number three is what's referred to as the evidence paradox. Despite almost now 20,000 randomized controlled trials, don't you frequently hear the following statement: we don't have enough evidence to effectively inform our clinical decisions? For those of you involved with guidelines making, we hear this all the time. We don't have enough good quality evidence. So how can we address this? We can address this by extending our research to more than just RCTs into the area of pragmatic research, where the research is done within a clinical setting, where we bring together teams of people, again, health systems, people, clinicians, patients as partners. And in doing that, we need learning healthcare systems that serve as the informatics platform around that. And so that leads me now to discussing some of the research studies that we've done with Choir. And as I said, we've published about 25 to 30 papers. I'm just going to give you a sampling of some of these on the left-hand side where we've studied fatigue, social function, physical function, tobacco, Botox, opioid misuse, and pain catastrophizing. And I'll go through these one at a time. Before I do that, though, I was thinking about this talk, and I was reflecting on the notion that the majority of the studies that we have done using Choir have been done by trainees. And Choir represents this incredible opportunity for trainees to get involved with easy to do research. Typically in our division, we take on 7 clinical pain fellows a year on the physician side, 3 pain psychology fellows, and we have a number of residents, and none of them can come into our lab and do anything meaningful because our research in neurosciences and brain imaging and whatnot is too complicated. But they can dive in to data using Choir, which has now got over 100,000 or more samples. So this is an example of an incredible young woman, Junie Carrera, who came out of McGill. Junie reached out to us. She connected to Beth Darnell in our group, and Junie was interested in doing a study with Choir data. And she was interested in social injustice and acceptance. Now, we weren't capturing this data within Choir at the time, but I said, Junie, just send us the surveys. We'll slip them in and then come on out. So she did that. And several weeks later, she got off the plane and we gave her 800 deeply phenotyped patients in just collecting it over a period of several weeks. And from that, Junie was able to generate 3 separate papers from this. And it led to her getting a postdoctoral fellowship where she's working at Harvard with now Rob Edwards. We would have loved to have kept her at Stanford, but we lost out to her husband who did a fellowship there. So diving into some of the research, one of the first studies we did, done by Drew Sturgeon, who's now at the University of Washington, was a structural equation model representing the influences of pain and sleep and depression on physical function, pain interference. And what we found is that all of these paths lead through this major node of fatigue, something we don't typically pay attention to in our clinical situations, and one that we are monitoring much more closely. We've also done some purely data-driven approaches. This one done by Ming Cao, our clinic chief and a Harvard-trained PhD biostatistician, did a Bayesian network reconstruction where it's throwing all of the data into the kitchen sink and allowing it to, if you will, self-assemble and define what are the major nodes and networks that define a pain experience. And what we found through this data-driven, non-model dependent approach is that social isolation was the major node. Now, there were other nodes too. Pain catastrophizing, fatigue shows up again. But social isolation was actually critical. And so Drew took this study and in a model-driven approach now, did another structural equation model. And what he started with was a basic premise. We know that when your pain goes up, your physical function goes down. When your physical function goes down, you get depressed, you get angry. But it turns out what really happens is your pain goes up, your physical function goes down. That leads to your becoming socially isolated, your satisfaction with social roles goes down. That is really what leads you to become angry and depressed. So we have been paying much more attention in our clinic to social functioning. And as a consequence, we've now developed and built in a number of self-management programs in partnership with the American Chronic Pain Association, where we provide free socially group-mediated programs to help build up the social functioning. You remember that story I told you about Sandra, where we put our treatments into play, everything got better except for physical function. Depression, anxiety, pain interference, physical function didn't budge. And what I've been seeing over hundreds, if not thousands of patients is that same exact pattern. And so I wanted to ask this question, well, one, does it matter? And two, is it representing something real? And the reason why I submit it matters is when you look at the national guidelines, whether in our country or your country, our state level guidelines, they all say to get approval for treatments, at least in our country, you have to measure pain and function, pain and function, pain and function. But when you open up the guidelines and you look at what are the surveys they recommend to measure function, they're all surveys based on pain interference. Physical function is how well you can do something. Pain interference is to what extent does pain interfere with your ability to do something. They sound very similar. Are they the same? It turns out they aren't. And it turns out they diverge very early and really don't represent the same thing at all. Now, this has strong policy implications because it really means that we're all recommending the measurement of the right thing, but we're doing it the wrong way. This is a study, again, I had to pull out one from Canada. James Kahn is a rock star pain medicine physician who did a fellowship with us. And he has a master's degree that he picked up when he was I think it was at Toronto, and came down to us, did his clinical fellowship, and wanted to dive into choir. And he did a couple studies, one on the impact of smoking. Now, why smoking was important is that while there had been past studies on it, it turns out there hadn't been much contemporary. And in the state of California, where we live, smoking is rather uncommon. Only about 8% of our population smokes. And the question is, does smoking represent a marker, if you will, of something bad? So he did a propensity score weighted analysis on thousands and thousands of our patients. And the short version is that if you smoke, you are by far worse off when you come in, and despite multidisciplinary care, you stay worse off. And this is even for controlling for all of as many of the confounds as we could identify. I tried to keep James at Stanford. We loved him, but unfortunately we lost out to matters of the heart. His wife brought him back to Canada, where he's now on faculty at the University of Toronto. And I just put this one in a few minutes ago. This is a study that Drew Sturgeon and James just published just literally a couple months ago on the role of cannabis. And here we collaborated with Mark Ware, who I believe is formerly at McGill and has an outstanding reputation in the area of cannabis. We used Mark's global cannabis questionnaire. We collected 8,000 patients. And let me give you just a short version of it. Similar to what we did with tobacco, what we find is that people who come in on cannabis are much worse off than people who don't come in on cannabis, using a propensity score matching. And again, despite multidisciplinary care, they stay worse off. Now, we can't establish a causal relationship in these kind of studies because we're not getting people before they went on cannabis. But it does help add weight to the information on cannabis, suggesting it's not as clear as we might think. I know there are studies out there that showing cannabis works in chronic neuropathic pain, for instance, but the large epidemiology studies are casting some doubt on this. We're now tracking this more on a long-term longitudinal basis. We can also use choir to do real-world pragmatic observational trials and assess the response to different treatments. This to Botox for migraines. Number of randomized controlled trials that were done for the FDA, Food and Drug Administration approval of Botox in the US, but does it work in the real world? And what we found is in capturing hundreds and hundreds of our patients, we find that in fact, Botox does reduce the headache frequency on a monthly basis by both a significant and a clinically meaningful amount. And there are predictors of who is more likely to respond. And it turns out a couple of the predictors are if you are of increasing age, older people tend to respond better. And then also those with lower levels of depressive symptoms also tend to respond better to Botox. Jennifer Ha, who is a physician researcher in our group, has been very interested in the aspect of prescription opioid misuse. She looked at several hundreds of patients within our group and looked at misuse behaviors. And I'm pulling out just one factor that was one of the strongest, rose to the top. And this I thought was fascinating, and that is around sleep. For every 1 hour increase in average nightly sleep, there was a decrease in opioid misuse by 20%. And that was fascinating to us. And so what we've done is to translate that knowledge into greater collaborative efforts with our sleep medicine center, which is on the floor above us. Finally, I'm going to take you down this path of how we use choir to generate rapid pilot data for studies, as well as generating knowledge about research. These studies, led by Beth Darnell, who is a researcher within our group, a psychology researcher, has had a strong interest in the space of opioids, sex differences, and catastrophizing. For those of you who don't know, catastrophizing is this abnormal cognitive emotional state that involves rumination about your pain or repetitive thoughts, negative amplification of pain, and a sense of helplessness or loss of control. So she led a study investigating the opioid use in our patients to ask, is there a difference between men and women? And is there a relationship with catastrophizing and likely to be on opioids? And what we found is the following. First of all, by taking thousands of data points, you can start to apply more advanced statistical approaches to your data than the typical linear approaches that are used. And here, using a generalized additive model, which allows us to do curve fitting, what we found was something intriguing. The usual story around catastrophizing is that it's clinically significant at levels of about 31 or so. But what we found, particularly with opioid prescribing, is that there is this heretofore unappreciated subclinical range here, which is actually quite meaningful, meaning that we typically are ignoring this whole range here, and it actually has a rather high impact. The question is, if you impact catastrophizing, does it make a difference in a patient? And so this is what Beth did. She took this information and she wanted to impact catastrophizing, but she recognized that the way we typically impact this is through cognitive behavioral therapy. The data is overwhelming that it works, and it typically involves, unfortunately, 8 hours or 8 sessions of very laborious in-session or in-person treatment. And our patients typically don't want to come to it because our traffic is bad, they're busy. So what she did is she developed a brief intervention, a 2-hour intervention, and she tested that in our clinic using Quire. And within a period of just several months, we were able to collect a large amount of data that showed that her intervention worked, turn that around into a NIH R01 grant application, and within several months, we got a $5 million grant to be able to study this. We've now finished the grant. We're writing up the results to be published shortly. And that's how you use real-world patients, real-world data to generate that type of pilot data and get grant funding. Now, shifting into this area again of opioids, we all know that there is an opioid crisis in the United States and that there is increasing pressures everywhere to reduce opioid prescribing and reduce opioids. Beth led this study in Colorado where, with a community sample, took patients with community doc and voluntarily weaned them down on their opioids. And what she found is that by and large, she could wean them down and that there wasn't, by the way, much change in their overall amount of pain. There were some people who actually did get worse. Some got worse, some didn't change, many got better. But she flipped this around into a multi-state PCORI trial called Empower. Now, by the way, just to be clear, Empower is our voluntary opioid reduction program. Empowered Relief is her single session psychobehavioral intervention. Unfortunately, they use the same term, but they're completely different. This is a multi-state program that compassionately weans people down on opioids. And we use Quire as the informatics platform here across these 4 states, running in the Google Cloud, that does automatic randomization of patients. It takes clinician-reported information, patient-reported information. The docs can get reports on how their patients are doing as they're being slowly weaned down on their opioids. This is some examples of 2 patients that we're seeing. We don't have the final data on this yet, but I'm just showing a couple examples. This is a patient who you can see we slowly wean down on their opioids, and by and large, their pain is unchanged. They're doing pretty well here. And you can see in this radar plot on these promise measures, the shaded area is the 6-month. This is the 6-month here. And you can see that everything tends to be moving in, and patients are by and large doing better coming off their opioids. But it doesn't always work like that. This is another patient who, in weaning down here slowly, what you find is that their pain is fluctuating all over the place. And while many things are not changing, they're staying about the same here from baseline to 6 months, one of the things that we see is worsening is their cognitive functioning is getting worse. What does this mean? Candidly, we don't know. But these are the types of questions that we need to address if we're going to be implementing these broad-scale opioid weaning projects across our country, and perhaps you're dealing with this in yours. So bringing a lot of the learning healthcare system together, this is a message that we need to ultimately bringing in data that represents the 6 V's. We need data that's high volume. We need to have a high variety of data from different sources to be able to characterize our patients. We need to have data with high variability so that we can model our patients. The data needs to have typically high velocity. This is represented typically by like actigraphy data that we might use, and the data has to be valid. One of the biggest challenges we see with EMR data throughout at least our country is that the pain-related data is of terrible quality and typically just not valid. And ultimately, we need data that's actionable. We need data that's going to be of high value to guide our clinical decision-making. So in closing things out, I want to share with you lastly where we're going in the future. And where we're building on this is through a collaborative approach with multiple academic centers, each building on features that we include into the code with Quire, and then we give out for free to everybody else. We've built in now the ability to do targeted intervention tracking. So for instance, we give out different surveys automatically for people getting epidural steroid injections, and different surveys for spinal cord stimulation, and different surveys for cognitive behavioral therapy, each targeted for those treatments where we want to determine, is the therapy working? We've built in the ability to do point-of-care randomization for comparative effectiveness trials, and we're running 2 CERs now that are grant-funded, one on high-frequency versus burst spinal cord stimulation, another one on duloxetine versus dicipramine. Mainly, these are feasibility studies to determine, can we do this cheaply and effectively within a clinic, because most clinical trials cost a lot of money, and we're doing this dirt cheap. We're building a patient-facing version where the patients can see their own data in real time. We have, we're using AI to give targeted delivery of content and referrals. For instance, patient education materials. We've partnered with the American Chronic Pain Association and are now developing their patient resource guide. We also give digital behavioral medicine interventions. I'm going to talk briefly about 2 interventions specifically around EMR using Smart on Fire, and then a distributed registry platform next. Smart on Fire is a new open standard, open platform model that allows you to integrate in smart web apps into EMRs. And it works through a Fire API to get there. What we have done is we've developed a version of this called Quire on Fire, which allows us to build web apps that integrate in to Quire and also allow us to pull and push data from the EMR. And so typically, let me show you how we're doing things at this moment in time in this COVID period. This is my typical computer screen when I'm doing a video visit or a telemedicine. I'm sitting there talking with Kermit, and I have got Epic, which is our particular EMR, opened up, and seeing Kermit's, or in this case, this is a test case, Rebecca Jones's information. And then I have Kermit's Quire screen opened up over here, where I can share that screen, by the way, with Kermit. I can walk him through the data. I can talk to Kermit about how, you know, he's got a moderate amount of depression. We hear he's not happy with his inability to connect with Miss Piggy. And we can use that for motivational interviewing. We can use that to help guide treatment. And then also I've got a typical screen up where I'm showing PowerPoints to a patient and doing education. but that involves a separate screen for Choir. Where we're going next is integration directly into the EMR, where you open up a window of Choir, a tab I should say, and then it's bringing up the Choir output that is going to be integrating information from both Choir and the EMR, and it's going to be doing this using sophisticated dashboards and reporting. What I'm showing you right here is the most rudimentary. It's really just a translation of our current reporting into this HTML window, but we're working on much more sophisticated visualizations. And I think this is going to be the future of where everything is going to be going. It is going to look like it's integrated into the EMR, but it's actually still running as a separate platform behind the scenes, allowing you to do all of your sophisticated AI clustering, targeted delivery of treatments, but fits into that kludgy EMR that we all love to hate. Lastly, very last, I think, couple slides here. One of the challenges that we face with aggregating data in a registry model is that it's expensive. Well, there's actually multiple challenges. It's expensive. There's trust issues involved with people sharing data. There are legal issues sharing data, particularly across international lines. So what we've developed is a model of a distributed computational registry platform where we can connect multiple sites, and instead of distributing the data, we distribute the source code. And through the magic of network statistics, we can converge on an exact solution where nobody's data ever leaves the local institution. We did this with 10,000 patients, 5,000, this is a proof of concept, 5,000 at Pittsburgh, 5,000 at Stanford. And what we find, just to give you the short version, is by and large, the people in Pittsburgh look very much like the people in Bay Area, with the exception of a couple differences. The people in Pittsburgh seem to have higher level of physical function than the people in Bay Area on average, and the people in Pittsburgh tend to be sleeping better than the people in the Bay Area. We don't know why, and again, it's just a proof of concept, but we're building on this with additional analytical approaches. So what are the lessons that we've learned from this as I'm closing things out? And I've learned a lot of lessons, both from the wins as well as the losses. I think the biggest lesson learned is that Choir is not an app. This is not something that you download off the Apple App Store and just plug in and expect it to go. It's an enterprise-level piece of software, and it requires a degree of hand-holding and communication, ideally with us, to help learn what are the lessons that we've learned to help you to be successful. In that, I would submit that the operational challenges of these types of platforms are much, much larger than the IT challenges. The IT challenges are real, but they're just not that big a deal. It's more about integrating it into your clinic seamlessly with minimal burden, and doing that while changing a culture. We recommend the KISS principle, keep it simple. One of the biggest challenges I see groups do is they try to boil the ocean. They go out there and they want to give all the surveys under the sun, and the patients revolt because it takes too much time. When we started in our clinic, we had a set of surveys that took people about 5 minutes to complete. And then over time, we build on it, we build on it, we build on it, we measure responses from patients, and we dial it in. Learn to embrace failure. You're going to make mistakes in this, but learn from that failure. Make sure you get all the stakeholders involved in this. That means the patients, the front office, the back office staff. Get the buy-in. I've already mentioned communication. With regard to, I said this is open source and free, but free should be viewed like getting a free puppy. There's a lot of care and feeding of this. It is not an app, and it does require a degree of care and feeding. We've been moving everything into the cloud. We've moved everything at Stanford. All of our patient data at Stanford research is going into the Google Cloud because we believe that Google, quite frankly, is much better at managing server farms than we can ever be. And the beauty of that is it lowers maintenance costs and allows easier dissemination of this code elsewhere. Finally, look at your data. Continually review it and adjust as you learn from your data and make the system better. That's what we've been doing. That's what Pittsburgh does, Medical College of Wisconsin, and on all of the other sites. So we've gone over kind of the challenges and the need for quality data. We've gone over the need for learning healthcare systems, and I've provided a use case of one that we've developed, Choir, as an open source model. We're looking to partner with smart people who want to collaborate, who want to add on features, where ideally you would share features back into the main code. We would give it out to the rest of the world, and our rising tide, if you will, elevates all of our ships, and we can ultimately make an impact on not only Sandra, but also all the other patients out there suffering from pain and other medical conditions. So let me close out, and I have to give my thanks to the people in our pain division who get all the work done. I'm simply the talking head, as well as our funding sources. Space didn't allow me to put all our collaborators in across the globe we're working on with this. And with that, I'll close out and delighted to answer any questions that you have, and really appreciate your taking the time out this evening to spend it with me and to chat about learning healthcare systems. Thank you.